It's 2 in the morning, he wakes up with pressure in his chest, not sharp, not dramatic, just a heaviness. Like someone left a hand on his sternum and forgot to move it, he thinks. Probably the pizza, he drank more than usual, he's been under stress at work, probably acid reflux. He lies back down, tells himself if it gets worse, he'll do something about it. It doesn't get dramatically worse. It just stays for 2 hours, it stays dull, persistent, wrong in a way he can't name but keeps dismissing. His wife wakes up and asks if he's okay. He says he thinks so by the time he calls 911. It's been 2 hours and 20 minutes since he first woke up. He survived. But 40% of his left ventricle was already dead by the time the catheter reached his blocked artery. That muscle will never contract again. His heart will work around it for the rest of his life. Compensating, adapting, carrying the weight of the decision made at 2 a.m. to wait and see. That is not a dramatic story. That is Tuesday. This video is about what happens in those first 10 minutes. They matter more than anything that comes after. What your heart is losing every minute you wait. And exactly what to do so that you are not the person who waited 2 hours because it didn't feel like the movies. Here is the number that should make you stop scrolling. 50% of all fatal heart attacks happen outside a hospital. Not in the ER after a delay, not in the ambulance, outside. Before anyone with a medical degree was ever involved. And the reason is the same in almost every case. The person waited to see if it would pass. This is not stupidity. It is not weakness. It is what the human brain does when a signal is ambiguous. Our threat detection system evolved for things that are loud and immediate, pain that screams, injuries that bleed. It did not evolve to respond to a dull pressure that might be indigestion. The calculus feels rational. This is probably nothing, and I will feel embarrassed if I call 911 for nothing. So people wait. They take antacids, they lie down. They tell themselves they'll go to urgent care in the morning. Meanwhile, the blockage in their coronary artery doesn't negotiate. Here's what the emergency medicine literature actually says about timing. Every minute of delay from symptom onset to treatment corresponds to measurable additional damage, not theoretical damage, quantifiable, permanent loss of heart muscle that does not regenerate. The window doesn't stay open. It closes, quietly, on a biological clock that doesn't care about your rational calculations. The emergency medicine term for this is time-dependent myocardial salvage, which is a clinical phrase meaning how much heart you save depends entirely on how fast you move. We're going to get very specific about that, but first, let's make sure you know what a heart attack actually looks like, because most people don't. Let's deal with the movie version first, because it is actively killing people in the movies. A heart attack looks like this. Man grabs his chest, staggers, collapses, dramatic, unmistakable. Everyone in the room immediately knows what is happening. That presentation, the classic crushing substernal chest pain radiating down the left arm, accompanied by cold sweat and sudden collapse, happens. It is real. It is also a subset. A memorable subset, not the typical experience. The rest are messier, more ambiguous, easier to dismiss. The chest discomfort may be pressure rather than pain, a squeezing sensation. Fullness, a heaviness in the center of the chest that feels vaguely like something is sitting on you. It may radiate to the jaw, to the neck, to the back between the shoulder blades, to both arms, not just the left. It may come and go rather than persist. Some heart attacks present primarily as shortness of breath, without significant chest pain at all. Some as sudden and unexplained fatigue. Some as nausea and vomiting. Some as a cold sweat with no other clear symptoms. Some as a vague sense that something is wrong without any specific location for the discomfort. This is where gender matters, and where the data has been consistently undercommunicated for decades. Women are more likely than men to experience atypical presentations. Nausea, fatigue, jaw or back pain. Shortness of breath without chest pressure. Not universally, but significantly more often. Research published in JAMA and reviewed multiple times by the American Heart Association has documented that women's heart attacks are less likely to be recognized by the patients themselves, by bystanders, and historically, even by emergency physicians, precisely because they don't match the male-dominant presentation that shaped the original clinical descriptions of coronary artery disease. That gap has costs, real, measurable costs in delayed treatment and worse outcome. Diabetic patients are another group where recognition consistently fails. The nerve damage that develops with long-standing diabetes can blunt or eliminate the sensation of chest pain entirely. A diabetic patient can have a full myocardial infarction with minimal chest discomfort. Their presenting complaint might be nothing more than fatigue, or nausea, or simply feeling unwell in a way that doesn't alarm anyone. So what do you actually watch for? Chest discomfort of any kind, pressure, squeezing, fullness, or pain, lasting more than a few minutes, or that goes away and comes back. Discomfort in the upper body, arms, back, neck, jaw, or stomach. Shortness of breath with or without chest discomfort. A cold or clammy sweat, lightheadedness, or sudden dizziness. An unusual fatigue that feels qualitatively different from ordinary tiredness. A fatigue with weight to it. No single symptom is definitive, but the combination, the context, particularly in someone over 40, with cardiovascular risk factors at rest or after minimal exertion, should override the instinct to wait. Here is the rule that emergency physicians apply. When in doubt, treat it as a cardiac event until proven otherwise. The cost of calling 911 for something that turns out to be acid reflux is a brief embarrassment. The cost of waiting to see if a heart attack resolves on its own is measured in dead muscle. Heart attacks don't look like the movies. That is exactly why they kill. Now let's talk about what is actually happening inside a blocked coronary artery. Because once you understand the biology, urgency stops feeling abstract. A heart attack, the medical term is myocardial infarction, begins when a plaque ruptures inside a coronary artery. Plaque is the buildup of cholesterol, inflammatory cells, and scar tissue that accumulates over years inside arterial walls. When a plaque becomes unstable and its surface cracks, the body responds as it would to any wound. It sends platelets and clotting factors to seal the breach. But the clot that forms inside a coronary artery doesn't seal a wound. It seals the artery. It stops blood flow to the section of heart muscle that artery supplies. That muscle needs oxygen continuously. It has almost no reserve within seconds of the blockage. The affected cells begin switching to anaerobic metabolism, burning glucose without oxygen, generating lactic acid, becoming acidotic within minutes. The cellular membrane starts failing. Ions flood in and out abnormally. Within 20 to 40 minutes of complete occlusion, the first cells begin to die, not impaired, not reversibly injured, dead. The medical term is irreversible necrosis. The tissue is gone, and this is where the math becomes critical. The amount of heart muscle that can be saved depends almost entirely on how quickly blood flow is restored. Researchers estimate that in a large coronary occlusion, approximately 1 billion cardiomyocytes, heart muscle cells, are lost per hour of sustained blockage. 1 billion per hour, on a clock that started the moment the artery closed. Those cells do not regenerate. The adult human heart has almost no meaningful regenerative capacity. What dies in those hours stays dead, replaced eventually by scar tissue that doesn't contract, doesn't pump, doesn't contribute. The surviving heart has to compensate for that permanent loss for the rest of the patient's life. That compensation has consequences: reduced cardiac reserve, higher risk of arrhythmia, higher risk of eventual heart failure. The current clinical standard for treating a STEMI, a complete blockage of a major coronary artery, is door-to-balloon time under 90 minutes. That means from the moment the patient arrives at the hospital to the moment a catheter restores blood flow. 90 minutes maximum. Every major cardiac center in the country is measured on this benchmark. But the clock on that benchmark doesn't start at the hospital door. It started when symptoms began. Every minute between symptom onset and the 911 call is a minute added to the total. Every minute between the call and ambulance arrival is another minute. The hospital clock is the last segment. You control the first one. Every minute you spend deciding whether to call 911 is a minute on that clock. And that clock costs about 17 million heart muscle cells per minute. You suspect a heart attack, yours or someone near you. Here is what to do, not the vague version, the specific version. Step 1. Call 911. Do this first before aspirin, before calling a family member, before searching your symptoms online, before anything else. This matters for a reason most people don't know. A 911 dispatcher can begin guiding you through the next steps while the ambulance is en route. They can tell you how to position the patient. They can walk you through CPR if the situation changes. And critically, they can alert the receiving hospital before the patient arrives. This is called pre-hospital notification, and it allows the catheterization lab to be activated and staffed before the ambulance pulls in. Research consistently shows that pre-hospital activation cuts an average of 20 to 30 minutes off door-to-balloon time. You calling 911 instead of driving is not just summoning a vehicle. It is activating a chain that starts saving time immediately. What to say when they answer. I think I'm having, or someone near me is having, a heart attack. The address is your address. The person is aid. They are conscious/not conscious, breathing not breathing normally. That is all. The dispatcher takes over from there. Step 2. Aspirin. If the person is not allergic to aspirin, is not on blood thinners that specifically contraindicate it, and is conscious and able to chew, give 325 milligrams of regular aspirin, chewed, not swallowed whole. Chewing bypasses the slower dissolution in the stomach and gets the active compound into the bloodstream faster. This is not a folk remedy. This is a Class I recommendation from the American Heart Association, the highest level of evidence-based guidance. Aspirin inhibits platelet aggregation, directly targeting the mechanism responsible for the clot blocking the artery. It does not dissolve the clot, but it slows platelet recruitment, reduces clot progression, and has measurable survival benefit when given early. Hospitals give it too, but earlier is better than later, and chewed is better than swallowed. If there's any uncertainty about aspirin allergy, ask clearly before giving it. If the person is already anticoagulated on warfarin, rivaroxaban, apixaban, or similar medications, skip the aspirin and tell the 911 dispatcher about those medications. Step 3. Position. Have the person sit or lie in whatever position is most comfortable. For most people, seated with knees bent, or lying with the upper body slightly elevated. Loosen any tight clothing around the chest or collar. Keep them calm and still. Physical exertion increases the heart's oxygen demand, the opposite of what you want when a section of it is already ischemic. Step 4. Do not drive to the hospital yourself. Every major cardiac emergency protocol makes this explicit for a reason. Driving while having a heart attack means no monitoring, no defibrillator in the vehicle if the heart enters a lethal arrhythmia, and a real possibility of losing consciousness behind the wheel. The ambulance crew begins assessment and can intervene en route. The car cannot. Step 5. Stay on the phone with 911. Do not hang up to call family members. Do not hang up to look something up. Stay on the line. Step 6. If there is an AED nearby, automated external defibrillator, locate it. These are now standard in airports, gyms, shopping malls, schools, and many public buildings. They are designed to be used by people with zero medical training. The device speaks. It assesses the rhythm itself and will not deliver a shock unless it detects one that requires it. If the person loses consciousness, an AED available within the first few minutes of cardiac arrest can be the single most decisive factor in survival. Step 7. If the person becomes unresponsive and is not breathing normally, or is only making gasping sounds, begin CPR immediately. Hands-only CPR without rescue breaths is effective and recommended by the American Heart Association for untrained bystanders. Place the heel of one hand on the center of the chest, just below the breastbone. Place your other hand on top. Press down hard, about 2 inches, and release fully. Repeat at a rate of 100 to 120 compressions per minute. The Bee Gees song Stayin' Alive is 103 beats per minute. That is not a coincidence. It is the actual mnemonic used in bystander CPR training. Hard, fast, don't stop. Do not stop until paramedics arrive and relieve you. Bystander CPR performed from the moment of cardiac arrest through EMS arrival has been shown to double survival rates compared to no intervention. In rural areas, where median ambulance response times can exceed 15 minutes, that window of bystander action is not supplementary, it is primary. Let's put the protocol in one place. In an emergency, structure is what survives. 1. Call 911, address, age, conscious, breathing. 2. Aspirin 325 mg chewed, not swallowed if not allergic and not on contraindicated blood thinners. 3. Sit or lie comfortably, loosen clothing, keep still. 4. Stay on the phone with 911. 5. Do not drive, wait for the ambulance. 6. Find an AED if one is available nearby. 7. If unresponsive and not breathing normally, hands-only CPR, center of chest, 2 inches deep, 100 to 120 per minute. Don't stop. 7 steps, make them shorter. Call, chew, sit, stay, don't drive, AED. CPR if down. 7 words, that is the whole protocol. One practical thing most people never think about until it matters. Does the highest-risk person in your household have aspirin accessible? Not buried in a bathroom cabinet, not in a bag that takes 90 seconds to find, somewhere known and within arm's reach of where they spend the most time. A small, specific action you can take today. Put a clearly labeled bottle of regular 325 mg aspirin, not baby aspirin, not coated aspirin, regular, in a location everyone in your household knows. Next to the phone, in the kitchen drawer, on the nightstand if appropriate, in a cardiac emergency. The 3 minutes spent searching for medication are not trivial. They are part of the window. Here is a fact that doesn't receive enough attention. 40% of Americans live more than 30 minutes from a hospital with emergency coronary intervention capability. A catheterization lab capable of performing angioplasty in rural counties. That percentage is significantly higher. In some parts of the country, the nearest capable facility is an hour away. For those people, the 911 to hospital clock begins with a structural disadvantage. The ambulance takes longer. The hospital is farther. The margin for delay. Recognition, in calling, in action, is smaller, not larger. This means that for a significant portion of the American population, what happens in the minutes before the ambulance arrives is not a bridge to treatment, in terms of tissue salvage, in terms of brain function if the heart stops, in terms of the outcome the patient will actually live with. It is the treatment. The system works well when all its parts are present and on time. Emergency cardiology in a well-equipped urban hospital is remarkably effective. The gap this video addresses is the gap between where you are and where that system begins. You're home at 2 a.m., 40 minutes from the nearest cath lab. Your annual physical gives your doctor 7 minutes. They will cover your cholesterol numbers, your blood pressure, maybe your weight. They will not walk you through this. The hospital assumes you'll call 911. The system assumes you'll know what to do. Now you do. Of one person in your life who is over 60, who lives alone, or lives far from a hospital, or has high blood pressure or diabetes, or a history of cardiac trouble, send them this video. You don't need to explain it, just send it, that's the whole ask. This video is for educational purposes only. Nothing here replaces emergency medical services or professional medical care. If you suspect a heart attack in yourself or someone near you, call 911 first. Always, the steps described here are bystander bridge measures based on current American Heart Association guidelines for pre-hospital cardiac response. They are not a substitute for hospital treatment, catheterization, or professional emergency care. If you or someone in your household has cardiovascular risk factors, speak with a physician about a written cardiac emergency action plan. That conversation is worth having before you need it.